I was diagnosed with an early stage 3 Churg-Strauss Vasculitis, keep picking up from what Karen was talking about, a rare and potentially lethal autoimmune disease. My treatment did follow all the biomedical protocols, and the disease was put to a halt. Although the disease progression was stopped, the illness was still there. It was lurking in the dark shadows, that's how I saw it, and it had the potential of rearing its ugly head at any moment. I had a biomedical physician who was a very kind and caring man, and when I started to talk to him about how this affected me, my future, my family, he couldn't really help me, but instead sent me to another biomedical doctor, Brian, who, he said, these were his words, works from a mind-body combination and has had significant success with complex illness like mine. It isn't an overstatement to say that the mind-body or this combined way of treating a patient transformed my experience with my illness. Within 2.5 years, finishing my chemotherapy, I was medication-free. And I was not only able to live my life free of the disease, but also of the ongoing anxiety of what's going to happen any day now. Is the illness coming back? As an agent of change in my professional life, I became really curious. I became curious as to why this profoundly effective and relatively, as a businesswoman, inexpensive way of treating people is not incorporated as part of routine care for people who have chronic conditions that impact on their lives and day-to-day livings. So I decided, in my naivety, to undertake a doctorate to help provide some insights that may play some part in shifting the conversation in the mainstream. So I decided to contribute to the discussion by producing an academically robust, yet practical piece of work that could provide a line of sight into the whole person therapeutic approach of other patients and their experiences with clinicians like Brian and others. As a patient, I was really intrigued and fascinated by the what of the whole person or mind-body approach. The idea that in some way my illness was meaningful in the context of my own life, and even symbolic. What I found, speaking to other patients, that it was the how of the experience that mattered the most for the people that I interviewed and whom interviews I've analyzed. It was the ways by which these clinicians established the therapeutic relationships. It was the relational dimensions of the practice that in of themselves were experienced as therapeutic, and I think it augments what you've heard from the previous speakers. For me, this is incredibly exciting because it means that any clinician, irrespective of the perspective on the connections between mind and body, can incorporate much of these ways of being into the clinical care. I undertook qualitative analysis of 29 interviews, and I used the questioning technique aimed at producing very practical insights. And I constructed 4 themes after this ongoing analytical process. In my mind's eye, I visualized this as a direction of travel towards an end or towards a distance where patients are freed from the burden of the chronic conditions. Even if they still have some of them, they are freed from the burden of them. The first theme or the first step in that journey, I called it seeing patients as persons and explicitly acknowledging the unique history. This is the first step of the journey because any patient who comes to any room is complex. They have lives, and those lives were fundamentally augmented because of the chronic conditions and the experiences with the health system. Clinicians who are able and willing to acknowledge the person, the patient as a person, are experienced from the very beginning by the patient, according to my research, as humanizing, and dare I say it, healing. The second theme, or the next step on that journey, is concerned with clinicians' ability to come across not as rigid professionals who are up there, who have all the answers and the patients just need to obey and follow and all will be right, but as people in relationship that are in tune with the person in front of them. So to that end, I call this theme clinicians bringing their whole selves into the therapeutic encounter. Because in the interview, the participants made it very clear that if the clinicians wanted them to bring themselves into the encounter, they themselves, the clinicians, have to be authentic. When clinicians were able to do so, they provided what was experienced as a very person-centered care. The participants described them as seeing them, the patient, as some kind of peers in a way, recognizing and valuing what they have to bring to care for their own condition. Often the things that seemed to matter most to the people I spoke to, they were able to discern very quickly and within the first encounter. It was how the clinicians phrased the questions, the body language, these little micro-actions. They were very astute and discerning them. And to that end, I named the third theme, negotiating those first encounters. This is where I pick this experience of being profoundly listened to. My thesis is called The Difference Between Being Looked At and Being Seen. So to that end, I broke this experience into 5 sub-themes, which were the art of listening, the heart of listening, the act of listening, the craft of listening and observing and acknowledging. And yes, this is a sell for you to read my PhD. So, drawing on my career, working in organization and coaching very senior people and executives to help bring about positive change, I know how scary, and as a patient, it is to fundamentally change your thoughts and beliefs that underpin everything in how we see the world. Thoughtful, mindful, careful, deliberate ways of communicating while on this journey underpins the success of any of those efforts. This is why, for me, these themes are very exciting, because they speak on the essence of practices and behaviors that can be undertaken by any and all clinicians. The fourth and final themes, or the end of the journey, addresses the change brought about through experiencing specifically the whole person therapeutic approach, which Karen spoke to. It explains the ways patients themselves experience the altering of their own beliefs about the illness and of health. I must reiterate here that this was only achieved while the relational dimension was in place. I called this a door into an understanding, which was again the words of the patients that I've interviewed. In how participants described this experience, the words spoke of having experienced a profound, transformative, as well as educational experience. They described how they gained an understanding of the connections between their personal histories, emotional experiences, and even spiritual states. My point of view is that in this world where change is escalating, and in healthcare, artificial intelligence and robotics are already seen to be encroaching on the domain of the highly regarded physician specialist, that of diagnostic and surgery. The human aspect of care is what these changes can never replace. I believe these changes provide an urgent imperative to bring about a shift in how clinicians are trained and practiced. I think that bringing about these shifts in clinical practice can be done, and it can be done through a whole range of things, including incorporating examination of the mind-body duality, which philosophically underpins how physicians and medical professionals are trained. And it can be done by insisting on systemic reflection on the power relationship in the context of healthcare. Thank you. After concluding nearly 4 years of research, I see this way of practice as having the potential to transform not only the lives of patients, but of clinicians as well.